My name is Nashmia Zia, and I'm a postdoctoral fellow at Dr. Gilbert Walker's lab at University of Toronto. And today I'll be talking about why early detection is a key for better prognosis and how nanocarriers can be used for timely diagnosis of liver fibrosis. Specifically, I'll be talking about exploring the use of GCPQ polymer, which is a modified glycol chitosan polymer and is specifically called quaternary ammonium polymethyl glycol chitosan, for the synthesis of technetium-99M radiolabeled micelles. And the use of these micelles for the non-invasive single positron emission computed tomography-based liver imaging for the detection of liver fibrosis. Now, before we go into the details of the methodology that was employed for the study, let's talk about why the detection of liver fibrosis is important. Now, liver fibrosis forms the basis of most of the chronic liver disease, and chronic liver disease is a very common ailment and leading cause of mortality and morbidity across the world. It is so common that it accounted for at least 2.2% of the deaths and 1.5% of disability-adjusted life years worldwide in 2016, and it's on the rise since then. Now, to understand the relationship between the liver fibrosis and chronic liver disease, let's take a look at the major liver cell types and their modification in response to chronic injury or the insult. As you can see from the figure, there are four major liver cell types: hepatocytes, hepatic satellite cells, macrophages, and cholangiocytes. Among these four liver cell types, hepatocytes is the most common and abundant liver cell type and constitute around 80% of the total liver cells. Now, they are involved in the uptake and metabolism of fatty acids, amino acid, glucose, bile secretion, so they are the most functional cell type of the liver. Whereas hepatic satellite cells are also called as scar-forming or fibrosis-inducing cells because under the influence of chronic injury or insult, they are activated to hepatic satellites activated type, and they start secreting extracellular matrix, which is composed of collagen predominantly. Now, then there is macrophages, which are also called as Kupffer cells, and they are the resident immune cells of the liver. And once under the influence of chronic injury or insult, they activate and form myofibroblasts, which secrete cytokines or inflammatory mediators. Now, then there is cholangiocyte. They constitute just 1 to 2% of the liver cells, and they are involved in bile secretion. And under the influence of injury, they become senescent or they stop functioning. Now that we know that there are major cell types and how they respond in response to chronic injury or insult, let's talk about different stages of liver disease and how liver fibrosis is generated under the influence of chronic insult. Now, liver fibrosis is a clinical corollary of chronic liver disease and involves excessive accumulation of extracellular matrix protein, including collagen, which replaces the normal liver tissue. Now, as you can see in this slide, that when the liver is healthy, the hepatocytes are also healthy and 100% of the hepatocytes are healthy. Under the influence or exposure of insult, the hepatocytes, the functional hepatocyte, the number of the functional hepatocyte decrease, and only 70 to 80% of hepatocytes are functional. As a result of which, the metabolism of fatty acid is impaired and the fat starts accumulating in the cells around the tissues. And that's when the liver is called fatty liver. If the injury continues, then the hepatic satellite cells are activated and they start secreting extracellular matrix or collagen. And this replaces the functional hepatocytes, as a result of which only 20 to 30% of the hepatocytes are functional at this stage. And this stage, the liver is called to have fibrosis. Now, if the injury continues beyond this point, the liver becomes cirrhosed or cirrhosis happens. And this is characterized by formation of nodular texture surrounded by fibrosis. At this stage, only 2 to 7% of the hepatocytes are functional. Now, an important consideration on this figure, or what important message that you can take from this figure, is that once cirrhosis is achieved or cirrhosis is reached, the injury to the hepatocyte is almost irreversible, and the only treatment option available for most patients at this stage is only hepatic liver transplant. It means that early detection is critical for better prognosis, because if we can detect the liver fibrosis stage, then it means that we have more options for treatment and the injury can be reversible at this stage. Now that we know that why detection of liver fibrosis is important, let's talk about the study design that we opted to do this. For this specific study, we opted to work with SPECT-based liver imaging. And it's a non-invasive technique of imaging. And we opted this because it is more functional as compared to CT and MRI. And development of the radionuclide for non-SPECT-based imaging is easier and cheaper as compared to PECT. Moreover, it's readily available worldwide because it's cheaper. So to do this study and to develop a radionuclide for SPECT-based imaging, we opted to work with glycol chitosan. We modified it to develop quaternary ammonium palmityl glycol chitosan, and we'll be calling it as GCPQ from now on. We developed GCPQ so that it has better affinity or comparatively better affinity towards functional hepatocytes as compared to non-functional hepatocytes, so that it can distinguish between fibrosis and healthy liver. Once we developed the GCPQ, we used probe sonication method to develop GCPQ micelles, which were then radio-labeled with technetium-99m using a stainless chloride reduction method at room temperature and a 10-minute reaction time, which is a very good thing. Once we developed the technetium-labeled GCPQ micelles, we did the in vitro characterization using TEM and radiolabeling efficiency determination, in vitro stability studies. We'll talk about it later. Then we did the biodistribution imaging, biodistribution using dynamic SPECT imaging. And after that, we did a proof of concept to make sure that our formulation can distinguish between control and fibrotic liver using a fibrosis liver rabbit model. Now to discuss the first step of the study, what we did, we took glycol chitosan, we acid degraded it, and then we functionalized it with palmitic acid. The idea behind is that the hepatocytes are very active in uptake of palmitic acid. So the idea behind this is that if there is more palmitic group present on the surface of the micelle, the uptake will be higher by functional hepatocytes. And then we did the methylation to improve the biocompatibility of the polymer. And then we did probe sonication to develop GCPQ micelles. Now, once we have GCPQ micelles, we checked the uptake in HepG2 cells, which are the hepatic liver cells. We developed 3 types of GCPQ cells with different level of palmitylation and quaternization to do a proof of concept where we can show that, okay, increase in the palmitic acid group on the surface would increase the uptake by liver cells. And in this study, in this slide, you can see that uptake is highest when the palmitylation level is highest, that is 35% of palmitylation level, as compared to P15, where there is 15% palmitylation and 15% palmitylation. So once we found out that the increase in the palmitylation level increases the uptake in liver cells, we did the cell viability study, and you can see that the cell viability is more than 95% for the Q9 P35 glycol chitosan micelles. Then we did the radiolabeling using a stainless chloride reduction method, and we determined the radiolabeling efficiency using a double strip method, and it's a method that is used in the clinics to determine the radiolabeling efficiency. And you can see that the impurities that are radiocolloid or the complexes are really low and around only 0.03%. Then we did the biodistribution study. I have not included the slides for that, but after that, once we had the biodistribution studies, we did a proof of concept in vivo validation using a fibrotic liver method. Now, to develop the fibrosis liver, we opted for rabbit liver. We opted for a rabbit model, and in which we induced liver fibrosis by carbon tetrachloride method, in which we mixed carbon tetrachloride with olive oil and injected it to animal for over a period of 8 weeks peritoneally until liver fibrosis is developed. To check whether the liver fibrosis was developed or not, we took samples. We sacrificed the animal and we took sample of the liver. You can see from these images, the healthy liver does not have purple thing, because purple is Mason trichome, which signifies the presence of collagen, and increase in the purple dye means increase in the collagen, means increased fibrosis. So once we developed a liver fibrosis model, we checked whether our formulation can distinguish between the healthy liver and the fibrotic liver. We injected the animals with our formulation, the healthy animal group and the disease model. And as you can see, at different time points of 6 minutes, 12 minutes, and 30 minutes, the uptake in healthy liver is higher and the uptake in fibrotic liver is significantly lower. This means that the uptake is because of hepatocytes, and the more functional hepatocytes present in the liver, the more will be the uptake, and that can be used as a negative contrast to distinguish between the healthy liver and the fibrotic liver, just to make sure that we are not we are being very specific. We did a blocking study in which we blocked the receptor by giving extra amount or high amount of the micelles beforehand, which was not radiolabeled, and then we gave the radiolabeled formulation to the animals, both to the control animals and to the animals with the liver fibrosis. And you can see that the decrease in the uptake is very prominent in case of control animal, but decrease in the uptake is not very prominent in case of the fibrotic animal. The reason being, in control animals, there were very functional hepatocytes, but when the hepatocytes were saturated because of the blocking, the uptake was decreased significantly. But in case of fibrosis model, the functional hepatocytes were very low to begin with. Therefore, the decrease in the uptake when there was blocking is not very significant. So we did the blocking study to make sure that we can actually distinguish between the control or healthy liver and the fibrotic liver, and these are the images for that. So the key takeaway point from this study is that we can improve the targeting of the functional hepatocyte by increasing the surface hydrophobicity of the micelles. And if we can do that, and if we can do the identification of liver fibrosis at an earlier stage, we can prevent the disease progression because we will have more options for treatment for the patients. And if this can be developed into a clinical modality that can be provided to the patient, it would decrease the financial burden on the healthcare system and improve the quality of life. Now, this research is already published, and if you want to go and check, this is the link for the study. And at the end, I would like to acknowledge Dr. Gilbert Walker, Dr. Abdurraza, and Dr. Adar Zia for helping me with the study, for NMIN for giving me the platform to tell you about it, and especially to the Walker Group because I've had so many wonderful years working here. Thank you.
So Nashmia, how did you ensure that you are imaging the technetium labeled nanoformulation and not the free technetium?
Thanks, Divya, for the question. It's a very good question. I have a slide, I guess, for this. So we can. It's a very important thing that you are actually imaging the formulation that you have developed and not the free technetium. So to ensure that, you need to ensure that your formulation is labeled with the radioactive nucleoid. In this case, it's technetium, and the technetium is not free, and you're not just like imaging that. So to do that, we did a serum stability study for the formulation, in which we incubated our formulation in human serum, and we checked the radiolabeling efficiency of the formulation at different time points for over a period of 6 hours. So it's a very good time period for the stability study, because usually when we inject in animals or in human patients, the total time period for the study is usually just 30 minutes to 45 minutes. So if it is stable, as you can see from this image, from this slide, that the stability was more than 98%. It means that 98% of the formulation was radiolabeled and there were no free technetium. So it means that for a period of 6 hours, the formulation did remain attached to the technetium. And you can also see it from the biodistribution images that I didn't show in the presentation. You can see the biodistribution of the free technetium is very different from the biodistribution images of the nanoformulation. Usually for free technetium, it goes to thyroid and is usually used for thyroid scanning. But here you can see that the formulation didn't go to thyroid, or the radioactivity is not visible in thyroid. It means that the free technetium was not present in significant amount inside the body of the animal.
Thank you so much.
Divya, I have a question. If
Mm-hmm.
no one else, if there's no questions from the other participants. First of all, Dr. Zia, thank you so much for your work on this novel preventive strategy, because I think early diagnosis will certainly, as you say, reduce the costs of liver cirrhosis on the health system if it's detected early. So with respect to your project, my question is about the manner in which specificity and sensitivity of the radio-labeled chitosan micelles were evaluated by the team in this study.
Thanks, Diana. It's a very good question. You want your formulation to be specific and selective for if you want to use it in the clinic. And we did this by doing two things, to be exact. One, to make sure that it's specific. We did the the blocking study that I already talked about. And I have an image here, which is showing the quantification of that blocking study. As you can see in this study, the uptake without the blocking and with the blocking is significantly higher in control animal as compared to the fibrotic animals. It means that the formulation can specifically differentiate between the control animals and the fibrotic animals. So this is one way that we made sure that the formulation is very specific for the fibrotic liver, and it would not identify a healthy liver to be fibrotic. And then we also have very good data about for the signal to noise ratio. As you can see, the target of interest is liver in this case. So the uptake in the liver should be very high as compared to the background organs. Otherwise, you will not be able to differentiate between the liver or the other organs that are taking up the formulation. And as you can see from the data here, that the uptake in the liver was very high as compared to kidney at all time points from 5, 10, 20, 30, 60 minutes, because the ratio of liver to kidney was very high. Similarly, ratio of liver to lungs was very high, and ratio of liver to blood was very high at all time points. So it means that there is a high signal to noise, the ratio, and you can easily distinguish between the easily identify the region of interest as compared to the background. So
thank you.
That's how it.
Thank you.
So what do you think is the potential advantage and limitations to the clinical translation of this imaging agent?
Thanks, Divya, for the question. I know at Anmen, we're always talking about commercialization and making sure that it reaches the clinics. So I guess this formulation has a pretty good potential because first of all, most of the formulation that are developed for identification or imaging of liver fibrosis are not developed at room temperature. So they have to heat the formulation for the radio labeling, and we don't have to do that. We can do it at room temperature. So it's very good thing if you want it to be translated into clinics, because you can do the preparation on site, and that's what is usually done on site, because the half-life of the technetium-99m is only 6 hours, so it has to be done on site. And if you can do it at room temperature, you're saving money, you're making it more cost-effective. Then, as I showed you here, we have a very good signal-to-noise ratio, so it's a very good thing. And it's it's biocompatible, as I showed earlier by the biocompatibility study in the cell lines. It's very biocompatible. It's more than 98%. The viability of the cells was more than 98%. And other thing that I would like to show you here is this graph. I didn't talk about it in the slides, but we did the kinetic modeling of the liver. And usually in clinics, what happens that because you're doing a non-invasive imaging, so you'll determine the kinetics using the images of the gamma camera that you're taking. So you have to do the region of interest and then plot a concentration versus time curve. And that's called graphical method of analysis. And from this figure, as you can see, this is the graphical analysis MA2. It's a multilinear regression analysis model, and it represents a graphical analysis model. And you can see that it's also, it has a very good fit, almost as good as from the compartmental model, which is a model in which the blood has to be analyzed to determine the concentration. Because I think it has a very good chance that it can be taken up by the clinics because we use the clinical modality to do the study. And the limitation, I would say, we don't have any intravenous preparation based on chitosan that is approved by FDA yet. So I guess that's a limitation because it would be first. Mostly people cite the inability to fully characterize the formulation as the reason. So I guess that would be a limitation in my opinion.
Thank you so much.
I might jump in with a final question before we run out of time. How can you be confident that your formulation was in fact taken up by the hepatocytes and not the macrophages in the liver?
Okay, thanks, Diana. Very good question, because we are talking about targeting the hepatocytes. And we actually did a study in which we injected the rabbits with the formulation, and then we excised their liver, and then we stained them. And this is the image of that slide, as you can see. So we labeled the formulation with FITC in this case. So the green is our formulation, and the black is India ink that was also injected into the animals. Now, the idea behind is that India ink is taken up by the macrophages or the Kupffer cells. So if our formulation were to co-localize with the macrophage, with the black dye, it means that they are also taken up by the macrophages, but that's not the case. The localization of our formulation is at a different place as compared to the localization of the India ink, which is known to be uptaken by the macrophages. So we concluded that the formulation is not taken up by the macrophages and instead taken up by the hepatocytes. We also have, I don't have those images here, but we also have HE stains slides, which shows that the formulation is taken up by the hepatocytes and not by the macrophages.
Excellent. Thank you very much.